Good afternoon and welcome to all attenders. And as mentioned, this World Cancer Report webinar will focus on the impact that COVID-19 pandemic has had on cancer screening programs worldwide. Can I have my first slide, please? So, since the first lockdowns last year, it has been clear that the response to COVID-19 pandemic was causing an unprecedented disruption of healthcare systems, diverting substantial financial, logistic and human resources away from clinical, public health and research activities which were not COVID related. A major consequence being that cancers missed out will occur later on, but at a more advanced stages and with worse prognosis. So to illustrate this issue and raise awareness, the director of the National Cancer Institute in the US has published on Science in June 2020 projections suggesting that over the next decade, approximately 10,000 excess deaths from breast and colorectal cancers are predicted to occur in the US. Next slide, please. Okay, so it has also become evident that to organize a timely and efficient response, appropriate management of remedial actions is essential. The availability of clinical and public health resources is affected by epidemic phases. During the phase of exponential growth, as you can see in this graph from a paper recently published by Dr. Basu and colleagues, healthcare systems are usually overwhelmed with the management of symptomatic cases, leaving little room for the management of other diseases. Whereas during the decreasing phase, on the other hand, healthcare systems may have some agency to deal with non-COVID disease, such as cancers. So the efficiency of a cancer screening program has to be optimized within a short period to cope with pending residual activities. Next slide, please. So to address the COVID-19 and cancer screening points, our guest speaker will focus on the following key points. First, what are the consequences of COVID-19 for cancer screening? Second, what challenges have been encountered by countries, both high income and low middle income countries? And finally, what could be turned into opportunity and what lessons have been learned? Our two speakers today will present different perspectives from both low and high income countries. First, I'm pleased to introduce Dr. Joachim Dillner, Professor of Infectious Disease Epidemiology at the Karolinska Institute in Stockholm, Sweden, and among other things, head of Karolinska Center for Cervical Cancer Prevention. Joachim, the floor is yours. You are muted.
Thank you very much, Jacopo. I will be presenting on the experiences of Sweden in coping with the cervical cancer screening during the time of the COVID-19 epidemic and in its aftermath. I do not have any conflicts of interest related to the vaccinations. And here is just to introduce the public health problem that we are facing. It's the cervical cancer prevention. It's still a very common cancer. It's more than 500,000 cases each year, where we fortunately know that it has an essential cause, the human papillomavirus. We are also well aware of the reasons of why there is such variability in the cervical cancer incidence all over the world. It is that the prevalence of HPV is different and that some countries have organized screening programs that push the incidence down. The developments in cervical cancer prevention that I will be discussing during this webinar that have come into effect during the last decade. The first one is the screening test to use. This was researched for about 25 years, but now there is global recommendation that the screening test to use is the human papillomavirus test. It's more sensitive and can be automated. Sample taking to use, it has also been a very large amount of research over a decade that it has been found that for HPV-based screening, it works just as well if it's taken by the woman herself in self-sampling. And then we have the strategies in order to achieve an elimination of cervical cancer by expanding on vaccination and screening. And the concept developed about 6 years ago called faster elimination of a cancer that involves a combined screening and vaccination at the same time that is predicted to reach a faster elimination. The first point regarding the use of HPV testing for better prevention of cervical cancer has been studied in many randomized controlled trials. This is the joint European trial that was published now 7 years ago, where it is seen that the cancer incidence, if you do HPV screening, the blue line, is much lower than the cancer incidence if you do cytology screening. And the other point that I will come back to later in this webinar is the fact that if you are negative in an HPV test, you are protected for a much longer time, such that you don't need to do screening as frequently. Then when it comes to how to take the sample, about 10 years ago, we were systematically trying to retrieve the actual costs that different countries in Europe were using on the cervical cancer screening. This turned out to be rather difficult, but one of the few countries where we knew exactly was the United Kingdom, because the National Health Service was paying this money directly to the screening. They sent invitations for screening for £12 million. They paid £92 million to the sample taker fees and £37 million to the laboratories for analyzing the samples. Now, even though the fees to sample taker are different in different countries and the cost of a self-sampling kit may be variable, the self-sampling is at least 10 times less costly than a physician-based sampling. Then I would also like to discuss the concept of the faster cervical cancer elimination. The concept is that by doing concomitant screening and vaccination, you will have the possibility to attack the groups in the population that are most effectively spreading the HPV infection at a given time point. This curve here, modeling done together with Jacopo Bausano a number of years ago, shows the incidence of HPV infections in Sweden before vaccination. It was very high if you were 17 or 18 years of age, but among women who were older than 35 years, it was only occasional infections, arguing that the vaccination should, as far as possible, try to achieve immunity in this group here that is propagating the infection. We've had organized HPV vaccination in schools with very high coverage. These women are now age 21, and we had an organized catch-up vaccination with 60% coverage. These women are now age 28. That would be about up to here. So it's only a very small number of age groups that are still propagating this infection, and it would make sense to try to reach those with combined screening and vaccination. Now, in Sweden, we had the problem that the cervical screening was very much fragmented because it's implemented at the county level. We had national guidelines mandating even a switch to HPV screening in 2015, and guidelines recommending self-sampling were issued even earlier. But in 2019, the status was that only a few regions were actually using the self-sampling, and many regions were still not using HPV for the screening. And there was not even a discussion on whether we should try to eliminate cervical cancer faster by combining screening and vaccination. Now, this is what happened when the COVID epidemic hit. It hit Sweden in March of 2020. And here I put the exact number of invitations for screening that were issued in the capital region of Sweden for 2019 and 2020. In April, it was just decided that all cancer screening and actually all non-emergency healthcare was cancelled. So about 200,000 screening appointments were not issued and simply cancelled. You can see here that the number of invitations issued went down from about the same as last year to actually nothing during the summer here. During the autumn, then it was allowed to issue invitations again, but the screening stations had a mandatory that there could not be crowding. So the capacity to issue screening invitations was very much smaller, as only a few women could be screened per day. This is the same statistics, but this is on the actual number of screened women resident in this region. We can see that actually already at the start of the epidemic, they started to not showing up at the screening station. And then it started to be a phenomenon with women who didn't receive appointments but somehow managed to get screened anyhow. But still the effect is quite big, with about 70,000 fewer women screened just for 1 year and 1 region in Sweden. To meet the challenge, what could we do? Well, with self-sampling, there is no crowding at the screening stations. And therefore, we started with a large-scale rollout of self-sampling. Just during 2021, there are 320,000 kits for self-sampling that were mailed out in the greater Stockholm area. And the other thing is that you can use self-sampling only if you're using HPV testing. It doesn't work if you're doing cytology screening. So this resulted in that the parts of Sweden that didn't use HPV screening now finally switched and followed the national guidelines on actually using HPV screening. And then the last one was a way to meet the screening deficit was to launch a faster cervical cancer elimination campaign with joint screening and vaccination, because women who are screen negative and vaccinated, they don't need so much screening in the future. So this was a way of meeting the screening deficit. There was a parliament decision in April, and it was implemented just earlier this week, actually. The faster eradication concept is that on top of a routine program of vaccination in schools and ordinary screening, you have a one-time campaign of HPV screening and organized vaccination, in our case, targeting women ages 23 to 26. It's a one-time campaign, and in this campaign, if you're HPV positive, you still need follow-up because the vaccines will not prevent disease then. But most women will have been negative, and when they are vaccinated, they can be released from the screening program, at least for the time being. So it helped greatly to reduce the screening deficit caused by the healthcare lockdown. To summarize, our experience was that it was indeed a major challenge. A healthcare lockdown with the cancer screening simply cancelled. And in the autumn, it was not completely cancelled, but there was only limited use of screening stations that was allowed, causing a large screening deficit. about 200,000 cervical screening appointments simply cancelled. However, this also resulted in new opportunities that I don't think would have happened had it not been for this major crisis. We have largely switched to self-sampling. It's a large saving of resources previously recommended for a long time, but we still kept to using our ordinary screening stations, but now we're actually using the self-sampling. The same thing with HPV screening. It enables self-sampling and less frequent screening, recommended even by a mandatory government decision in 2015. Now it's actually used. And then finally, the faster cervical cancer elimination by concomitant vaccination and screening. It should rapidly stop the circulation of HPV and enable less frequent screening. Previously, we had not even had a serious discussion, but now it was both decided on by Parliament and implemented in a very short time. So I think one can say that we have risen to the challenge. Thank you very much.
Okay, so thank you very much, Joachim. I have one point for the audience. Now you can start posting your questions on the first intervention, and then we will deal with them later. And now it's my pleasure to introduce Dr. Partha Basu, who is Deputy Head of the Early Detection, Prevention and Infectious Branch at IARC. His research areas include evaluation of new strategies for control of cancer screening programs in different countries, in particular in low middle income countries. Partha, please go ahead.
Thank you so much, Jacopo, for the very kind introduction. Let me share my screen. Hello, everyone. What I will do is I will give the perspective of the low and middle income countries, taking Bangladesh as a case study to understand how COVID-19 pandemic has affected the cancer screening program in these countries. Undoubtedly, we are facing the worst health crisis in our generation. As you can see from this particular map taken from the WHO coronavirus disease dashboard, none of the countries have been spared. Already 3 million people have died out of this disease, and the number is still counting. And just because I'm going to discuss Bangladesh, I can put you I put the figures from Bangladesh. There have been about 11,000 deaths in the country. Bangladesh as a country, it is one of the most densely populated countries in the world. The population in the country is 3 times that of France. It's a low and middle income country, but then in terms of many of the health and social indicators, in the recent times, the country has been doing reasonably well. Coming back to the question of pandemic, if we look at the WHO definition of pandemic, a pandemic is declared when a particular disease happens in a large number of the population, transcending the geographic boundaries. Generally, it is used in the context of infectious disease. But I am going to argue that cancer is a pandemic. None of us can deny the fact that each and every every country in the world has been affected by the disease. We know that 10 million people die of this cancer every year. Maybe at least 30% or 40% of those deaths could be preventable. And more importantly, hopefully in another year, another 2 years, the COVID pandemic will disappear. But the cancer pandemic will not disappear. It will become worse. If you look at the graph on the right-hand side, we have divided the different countries by their Human Development Index, which is a composite index taking into consideration economic, social, and health indicators. And as you can see, the countries with low HDI, or I'm sorry, or medium HDI, they are going to see about 75% to 100% rise in the cancer incidence. And this is going to really overburden the system, creating a new crisis for these countries. And until and unless we focus more on prevention. And one of the most effective prevention measures, what we call secondary prevention, is cancer screening. So we did a study, and I thank my colleague, Dr. Patricia Villain, for leading this study. So this study aimed to look at the impact of COVID last year on a certain number of low and middle income countries. We directly approached the Ministry of Health of those countries for which we knew that they had a cancer screening program. Through the Ministry of Health, we directly approached the cancer control program coordinators. So we did a questionnaire survey to understand the impact of COVID in their respective countries. And that survey was followed by an in-depth interview of the program coordinators. It was held generally between July to September last year. So on the map on the left-hand side, you can see that we have included 17 countries across the globe. And they are representing almost all the continents. The red arrows indicate that when we did this study, these particular countries were still showing a rising incidence of COVID. And here is the list of the countries which some of them are belonging to the low human developmental index, some in medium, some of them are high HDI category. On the right-hand side, here is the impact shown on screening, diagnosis, and cancer treatment. Almost all these countries, they had cervical cancer screening program. Some of them did have breast cancer screening program, and only a few said that they had colorectal cancer screening. So we found that cancer screening was suspended for 30 days or more in all those 17 countries except 4 countries. Suspended means that there was no screening activity at all. In terms of the diagnostic activities, both for screen positive as well as for symptomatic people, for cancer, diagnostic activities were suspended for 30 days or longer in 9 of these countries. And what was most worrying was that even cancer treatment services were suspended for 30 days or more in Bangladesh, in India, and in China. We asked these program coordinators in terms of their perception of the availability of screening, diagnostic, and treatment services at that point of time compared to the pre-COVID days. So here you can see, say for example, Bangladesh. The first column is indicating the proportion of screening activities ongoing. So it is about 15% as compared to the pre-COVID days. Then the second bar is showing the diagnostic activities. You can see the severe impact. You can see the severe impact on treatment activities, which is shown by the third bar. Now, interestingly, when we look at these different countries by their human developmental index, countries with high HDI, they were not that much affected. In fact, countries like Thailand or Sri Lanka, which had better organized health system, they were much less affected. On the other extreme, the countries with low HDI, they were also not showing that much of affection. It was essentially because when we did this study, these countries were just showing the rising incidence of COVID. So there are not too many deaths, not too many cases happening. But then the maximum affection was for the countries belonging to the medium HDI category, including Bangladesh. Now, what was the reason? In our study, we also collected information of the reasons, which are more or less what was found by the WHO survey that looked at the impact of COVID on non-communicable disease control programs, and 122 countries responded to that. 163 countries responded to the survey, and out of those, 122 countries said that NCT program was significantly disrupted. And what are the reasons for that? 37% they said that there was closure of screening activities. 32% said that they had staff redeployment to manage COVID. Outpatient closure was a major problem for many of the countries. Many of the countries, they didn't have sufficient protective equipment. Insufficient staff was a problem, and then stock out of health products. So this is from systems perspective. From the perspective of the clients, individuals eligible for screening, obviously we know they were quite afraid to come in contact with any health facility because they didn't have apparently any problem. And there was another important aspect we need to consider. A study in Pakistan very clearly showed that irrespective of the level of service provider, every service provider was feeling emotionally exhausted, and that staff burnout was also a major problem for these staff being involved in cancer screening programs. Let us come back to Bangladesh, and let us see what are the things that Bangladesh did in terms of keeping their cervical cancer screening program on track. Bangladesh, they have a VIA-based cervical cancer screening program targeting women between 30 years and 59 years of age. And this is a purely opportunistic screening program till last year. As you know, for any cancer screening program to show the appropriate impact, it has to be better organized. That means there has to be a system of inviting the eligible population, and also to make sure that the positive women or men, whatever type of screening may be, they are appropriately managed. And to do that, we need a health information system. And a screening program is very, very difficult to implement without a health information system. The screening program in Bangladesh, they took advantage of a health information system that is freely available across the globe. So it is called DHIS2. It has been developed by the University of Oslo. It is being supported by the WHO. And in the map on the right-hand side, you can see that so many countries, and almost all of them are LMICs, they are using this particular program to manage their different health programs. Now, WHO came out with a guideline and a module to how to adapt the DHIS2 program for cervical cancer screening. Very few countries have actually adopted that, but Bangladesh did that. They started introducing the cervical cancer screening module in 2017, and now they have a working information system. And because of the COVID, this information system was extended right up to the last mile, which is their health post in the villages. And so the screening program now can collect individual data right up to the last mile, that is their rural community level. So this is a big development that has happened during this pandemic for the program. And because of the health information system, Bangladesh could provide data on the impact of COVID on cervical cancer screening. Very few LMICs have this data. So here you can see the graph. The first two lines, these are the number of screening happening in the country in 2018 and 2019 by the different months. As you can see, this is more or less a straight, these are straight lines, more or less superimposing each other. But in 2020, after the COVID pandemic happened, and then there was lockdown, you can see the sharp decline in the number of women being screened. But then over time, it gradually recovered, and recovered to the level that is expected. But during this period, few 100,000 women have missed screening. And in the background bars are showing the number of COVID cases happening in the country during different months of that in 2020. So what Bangladesh did was very interesting. The COVID outbreaks, they were much more severe, especially in the Asian countries, in the urban areas. So the urban areas were maximum affected. So the program managers, they took a decision that they would now concentrate more on the hard to reach areas where traditionally screening was much less. So they used a campaign mode. So in this campaign mode, screening facilities were set up in the most rural outreach health posts or village posts, where women could come, they could feel more secure rather than going to a district hospital or a primary health center. So in this village post, they could manage to screen adequate number of women. So that is why you can see whereas in southern part of Bangladesh, which are more urban, there was significant drop in the number of women screened in the year 2020. In these areas, there was actually a significant rise in the number of women screened. The COVID very significantly impacted the attendance to the colposcopy clinic. So this is the data which is from the largest colposcopy clinic in Dhaka. As you can see, that number of attendees from all the different districts of Bangladesh, they were significantly reduced in 2020 compared to 2019. So again, the program managers took a decision that they changed the protocol of management. Earlier, all the VIA positive women, they used to be referred for colposcopy. So they changed that practice. They used a magnifying device called gynocular immediately after screening, and then those who are screen positive, they were immediately treated. So what we call screen and treat. So they changed their protocol from screen, colposcopy and treat to screen and treat. And that is why they managed to treat a significant number of VIA positive women. So to summarize, what are the strategies that paid dividend in Bangladesh? Number one, the program didn't lose priority. It was essentially because of good leadership. The program coordinator remained part of the COVID response team. Strategic planning to prioritize the hard to reach women. So that I have shown that they have changed their strategies and tried to bring in those women who are traditionally not screened. Screening facilities created away from regular health facilities to give the women a sense of safety. Revised management protocol to introduce screen and treat, being flexible. The staff training curriculum, it was modified, and the curriculum included COVID mitigation measures during screening, colposcopy, and treatment. That's very, very important. They started developing the information system to monitor screening program in 2017, 2018, but then the pandemic was an opportunity to expand it to the last mile. So this pandemic has taught us a few lessons. It has taught us that to build back the health system better, especially when we are talking about preventive programs like screening, we need to emphasize three things. Number one, we need better governance. Number two, we need better preparedness and planning. And number three, we need to be more adaptable and more flexible, both in terms of resource allocation as well as service delivery. I will finish my talk by thanking Professor Ashraf-un-Nessa from Bangladesh, who has been extremely helpful in providing the data. Thank you very much.
So thank you, Partha, for this very extensive presentation. We are on time, so we are meant to close the webinar at 3:15, so we have about 35 minutes left. So I would move to the Q&A session. It will work like that. I will address questions to one of the panelists, but if the other feels that he needs to respond, feel free to go on with that, okay? So I will start reading the questions. I am not reading the name of the person asking the question to not make mistakes and not to lose time. So the first question is, I mean, a few questions about self-sampling. So the first question is for Joachim Dillner. What were the reasons why self-sampling were recommended but not actually used in Sweden prior to COVID?
First, it is an extensive amount of scientific literature showing that it is at least as good as physician-taken samples for HPV testing. At the latest systematic review, we located 38 such papers where most of them had excellent or very good kappa statistics on the results when they had been doing that. So it was clear that it was equally good, and it was also clear that it was less expensive. The use that we were advocating before COVID was to systematically send it to women who don't show up for an appointment at a screening station. We've had a system with screening stations where women are sent to the nearest screening stations for now 60 years, and we saw very little reason to change that. So the recommendation was that if it didn't come, send them a self-sample. And this was instituted only in 4 out of 21 regions. And exactly why, I'm not really sure. It's a sort of a loop in the program that hadn't been there before. And it takes time for program to change. They have many priorities on what to do. And when it was just one more thing to change, maybe it was not sufficiently prioritized. Now with COVID, the situation was entirely different because we couldn't use the screening stations, or they had very limited capacity because of the non-crowding rules. So now suddenly we had to use it. So I think that was the main difference.
Thank you, Joachim. So now it's again a question on self-sampling, but for Partha. So how relevant is self-sampling in low middle income countries? It's a very wide question, but important.
Thank you for the question. I think very interestingly, in the low and middle income countries, all the studies that we did in Africa, in India, we found that the acceptance of self-sampling was extremely high. So for example, in a very rural heartland area of India, we did a study where we invited, where community health workers went house to house and counseled and advised the women to provide self-sampling. Initially, we were quite hesitant, and then we didn't know how the response would be. But 90% of the women, they provided the self-collected samples, and then out of those women who are positive, 76% of them, they came to the clinic for further evaluation. So that shows that the self-sampling is not only, we need to talk about self-sampling in high resource settings, but then also in the LMIC settings, it has a very, very high relevance. And I'm sure as with time, the cost of HPV test will come down, and as Joachim has very clearly shown, that it saves a lot of resources. So for LMICs, again, the self-sampling is the way to go. And in the post-COVID situation, it will be even more relevant. Thank you.
Okay, again, on self-sampling, is the medical profession or the medical, the healthcare workers are supporting the self-sampling both in Sweden and in LMIC? What is your take?
Well, who should say about that? I think that it's of course there is a certain amount of conservatism that people like things to be as they have used to be, and sometimes I do hear that the question on that fees are being paid where they would still like them to be paid but it's not really a major cause of resistance. I think it's mostly a case of that screening needs to be prioritized, because the energy for change is sort of limited. There are so many things that need to be changed in healthcare, and cervical screening is only one of them. So I think it's mostly that if the screening per se receives higher priority, there will also be change.
I mean, if I have to give the LMIC perspective, I mean, in our studies, we use the community health workers. And again, with training, and then when we give them a kind of visual aid, they could very successfully counsel the women. And they were, the feedbacks we received from the community health workers was good. In the primary setting, I am sure the nurses will be extremely glad if they don't have to go for speculum examination. That's not a real problem. We had faced some hesitancy among the gynecologists. But then, as we have now excellent data coming from meta-analysis, for example, by Mark Harbin and all, which shows that it doesn't matter, whether it is self-collected sample or it is a provider-collected sample, especially if you are using an HPV detection test that is PCR-based. It has exactly the same, sensitivity. So now with that, the gynecologists are also now being convinced, and they are also kind of accepting self-sampling.
Okay, thank you. So I have a question for Joachim, and it's quite technical, but I think it's important. So the question is that I presume that HPV positive women will be recalled to their GP for cytology triage. Maybe you mentioned that, but I mean, it's good to repeat. Have you considered repeating HPV test after 6-12 months to reduce the charge on overwhelming colposcopy clinics?
Yes, I think I could consider this time point, in particular to the HPV screening of young women. As you are aware of, the HPV prevalence is strongly age dependent, and among women below the age of 30, the HPV prevalence is used to be so high that they are overwhelming the colposcopy clinics or even the midwives who take a new reflex cytology test. However, in this age group, there has been a major change in HPV 16 and 18 prevalence because of the vaccinations. The HPV 16 prevalence are down to maybe a fourth of what it used to be, and HPV 18 prevalences are even lower. It's like 10% of what it used to be. So the amount of women with 16, 18 in the group below 30 is no longer large. So it is not expected to be a problem to send these women for a repeat cytology at the nearest screening station. The problem is the HPV types that are not present in Gardasil 4 because their prevalence has not been reduced at all in the screened birth cohorts. However, in this age group below 30, the number of cases of cancer caused by non-Gardasil 4 HPV types is extremely low. So there they are considering to postpone a follow-up of women with these non-vaccine types in order to not overwhelm the system.
Okay, thank you. There is a question I ask Partha to answer. It's not exactly on screening, it's more on vaccination, but there are many people ask similar questions. So COVID would also impair the vaccination program. How do we circumvent that? I think it's important to give an idea at least.
Sorry. Yes, I mean, there is enough information even from the LMICs that there has been a substantial drop in vaccination during and following the COVID outbreaks. But then, you know, it again depends on the resilience and then the adaptability of the system. So recently I was discussing with the HPV screening program coordinator in one of the states in India that has introduced the vaccine. And they said that they follow a campaign mode. It's like in a certain month of the year, they go ahead and then plan and then they go for the vaccination. So the way they planned their next campaign was in between two outbreaks. So they didn't feel that they have missed much. So again, it comes to how the things are planned and how the things are implemented, taking into consideration that this kind of waxing and waning will keep on happening. So we'll have to be prepared for that, and we'll have to plan and make sure that we don't miss too many target, you know, here we are talking about HPV vaccines, so target girls. And another important thing is that in the UK, there is the JCVI, which is the Vaccine Advisory Committee. They came out with a recommendation based on the data that we already have on the efficacy of single dose of the HPV vaccine, that first prioritize giving the first dose of the vaccine, and then think of giving the second dose of the vaccine. So this is again another approach that some of the countries you know, adopted for HPV vaccination, prioritizing giving the single dose to the girls who are coming to the schools, and then to consider how best to follow them up with the second dose. Thank you.
Okay.
I can say that it is important to see that there is both disruption caused by the pandemic, but that it can also create opportunities. I didn't tell you exactly how we were planning to do this campaign of vaccination and screening, but it's actually the same campaign that we are using to vaccinate against COVID, such that what we are piloting now is that when we have a campaign intended to vaccinate the entire population against COVID, when we are done with that, they continue with HPV and HPV screening. So it's sort of building a national campaign to do this in a campaign mode is what we think is what fits best to a post-COVID situation. Everyone is used to that. Campaign is the thing that we can do to cope with the situation.
Okay, Joachim, we go on with you. And I think it's a very interesting question. In the sense, you said that COVID accelerated decisions that were maybe encouraged but not taken before. So how could we help accelerate these sort of decisions without the pandemic?
Yeah, I'm not really sure. The thing was that we had already the government decisions on, for example, self-sampling and HPV screening, but they were not used anyhow. So the reasons why also government decisions were not implemented, I'm not entirely sure. I think it was a question of priorities and what actually fits the work in the healthcare. In this instance that we now had with the joint vaccination and screening, it was a matter of weeks between the parliament decision and before it was implemented. And I think this is because it was a real healthcare need, and that everyone in healthcare understood that the screening deficit was a large problem that needed acute attention and priority in order to prevent unnecessary cancers. I think that this sense of acuteness and emergency is what really speeded up the implementation after the decisions.
Thanks. So Partha, there is a question now. It moved. Yes, that's it's very operational. It's Partha. Is there any guideline or document by WHO or IARC to guide the reopening of cervical cancer screening programs or any other institution?
Yes, some of the national programs, they do have guidelines. But then from IARC, we published a paper in the Journal of Global Oncology, and you were also part of that. And then some of us, we came together and tried to look at how best to make sure that cancer screening continues during and after the COVID outbreaks. And we looked at from different angles. Number one was from the governance perspective. How do we, how do the programs get prepared and plan to keep the services on track? Second perspective was how to ensure the safety of the participants who will be coming for screening. So there are specific, point by point guidelines. And then what we really emphasized on was that screening, of course, is important, but the most important part is to ensure that the people who have cancer diagnosis or suspected cancer, they are appropriately taken care of. So for that also we included guidelines. So this JGO article published I think last month will be very, very interesting for people to read, and then there are specific guidelines on that. Thank you.
So yes, this is for you, Joachim. Following the fact that screening has been on hold during the pandemic, are high-income countries considering inviting women at higher risk first? Is there any risk stratification in the invitation?
That's almost my favorite question. It's indeed, we are still doing all over the world invitations to screening to everyone at regular intervals, even though we know that the risks in the population vary quite a lot. As some specific example, I can see that a woman that has already attended screening 10 times with normal cytologies will have a cervical cancer risk of below 1 per 100,000. And it's not really meaningful to invite her for an additional a few screenings. On the other hand, if you've been positive for some of the most oncogenic HPV types, like 16 and 18, the risk that you will be coming down with a cervical cancer or pre-cancer during the next 10 years is greatly elevated. And I think that sooner or later we will come to a stage where we need to prioritize to ensure that the high-risk women have almost a complete attendance in the screening program in order to make them as efficient as possible. The focusing will be necessary. This broad strategy is more a time of the past, when we were not really able to predict future risks in the way that we are today.
Okay, this is a question I think for both, but start with Partha. So Bangladesh and Sweden, thanks to scientific and managerial leadership, managed to transform a threat or a threat into an opportunity, essentially. Do you have, are you aware of any other settings in low middle income countries and high income countries in which this kind of virtuous approach happened?
Maybe Joachim, if you'd like to go.
No, it's really a little bit of a problem that that in the time of the epidemic, everything was so urgent that a lot of the normal communication between countries didn't happen. Also, there were, of course, travel restrictions such that many of the societies in the screening actually didn't meet. So I'm not really sure if there exists a good summary of what really happened. I know the International Cancer Screening Network is working on it, but I haven't seen the results yet.
In the study that we did in 17 countries, we came across several different approaches that the countries followed. Say, for example, there were countries like China, India, and Sri Lanka who said that they were using online portals to give appointment, to deliver results, and provide telecounseling for the screen positive women. There were countries that like Iran, they tried to develop the COVID-free hubs. That means the centers where there are no COVID patients brought in, so the men or women undergoing cancer screening or immunization or that kind of preventive interventions, they could come there safely. So this kind of COVID-free hub was created in Iran. Some of the countries like Zambia, Rwanda, they said that they provided transport support to the patients who are screen positive or suspected to have cancer. And then some of the countries, they said they were very innovative in creating a group of young volunteers group who were navigating the patients, especially the cancer patients, to how to reach the cancer center, get appointment, because at least during the first wave of the outbreak, the young people were spared. So the young people were more they were encouraged to come and then provide voluntary services. So we did see quite a few, the innovative solutions that even the LMICs they came up with.
Okay, so Art, I think it's again to you, but then Joachim can also answer, and it's very much related. So you said that basically one of the lessons learned is that we need a better governance. So the point is, how can international institutions or large institutions support these and promote this better leadership and governance? What can they do, if anything?
So yes, in terms of governance, means there has to be a rapid situational analysis. Based on that, there should be appropriate planning, and it cannot be isolated. Normally what happens is cancer screening is looked at as a fragmented approach. It should be a comprehensive team, which is part of the COVID response team. So even the NCD prevention and other things. So there are different governance mechanisms which are there to make sure that things are on track. And there are adequate guidances which are there from the WHO. In fact, WHO has a manual on how to ensure continuation of the non-emergency services like non-communicable disease screening, prevention services in the face of the COVID crisis ongoing. So that manual is freely available in the net, and then I would encourage people to access that. That gives very nice guidance in terms of governance in the face of COVID crisis.
I would like to state that I think that I've seen that particular in my own country, but also in some other countries, it appears that the preparedness for crisis had mostly been planning for security crisis rather than healthcare crisis, and that the ability to cope with a rapidly occurring healthcare crisis was limited. And I think a lot of the countries will undoubtedly be preparing to ensure that we have an appropriate preparedness for healthcare crisis for the future, and that should also consider on how to deal with, so to say, collateral damage on cancer screening that any crisis will have in its path as well.
Okay, I mean, while you're replying many other questions about emergency plans and this kind of thing, so I will skip them. There is a question which is part, I think it's the point is that beyond the suspension of the services by the providers, is there any hesitancy from the women to attend crowded places? It works also, I think, in Sweden, it is regulated, I think. But do you have information, or have you studied this aspect? How hesitancy to attend screening has impacted the screening?
Yeah, I mean, in a way, it is quite obvious and then understandable that this will happen. In the qualitative study that we did among the program managers, we asked them what they rank as the top causes that will prevent the screening to return to track in the next 6 months to 1 year. And 60% of them, they said that this will be a major problem. The hesitancy of the apparently healthy people to come and then seek screening in the health facilities. So yes, this is going to be a problem. And then I did come across a study in UK where they looked at the different primary care facilities, and then they showed that there was a significant drop in the diagnosis of new cases of diabetes. So that also shows that people are not either going to the primary care, even if they have problems, or if they are advised some tests, they are not undergoing the tests because they are quite afraid even to go to the laboratory services. So yes, that's why the importance of keeping either COVID-free hub, which is not practical in many settings, but then at least making sure that the part of the hospital or part of the clinical services that is taking care of cancer screening is made as much free as possible from the COVID patients coming in. That means there should be a separate entrance for the COVID patients or suspected COVID cases. All those COVID tests and other things should be done in a separate part of the building or the facility. So there is again specific guidance. Again, I would like you to consult the WHO NCD guidance to minimize or mitigate the COVID infection risk, to understand how best this kind of things can be organized in a real health setting. This will be very, very important.
I could just state that I actually showed this data we had from Sweden. This was from March 2020, where the attendance after an invitation dropped drastically. In April 2020, we had it was lockdown, so then it was not sent any longer. But already in March 2020, the women started to not showing up after an invitation, no doubt because of worries about crowding. So it's really a real concern, and how to be able to cope with that, particularly if it happens rapidly.
Okay, so I put together two very basic questions just to go to the basics. So the self-sampling kits and the HPV test, are they available in low middle income countries? It's very simple but important question.
Yeah. See, for self-sampling, you don't need a separate type of HPV test. It's the same HPV test that is used for provider collected samples that is used for self-collection. That's number one. Number two is the sampling device. There are a lot of different types of sampling devices that are available. But then in our studies, we used either the Digin, brush that is used to collect samples from the cervix, or Digin hybrid capture 2 test, or a swab. This we found, women found this less intimidating or less complex rather than more complicated, self-collecting collection devices that are available. So Yes, even in the LMICs, any HPV test that is validated and that is accepted for cervical cancer screening can be used for self-collection. And then we have several options to use different types of collecting devices. But then the brushes and then the swabs, they work best well in our experience.
Okay.
I could perhaps add that it's a little bit of a problem that the pricing in the self-collection devices is clearly different, obviously intended for different countries that have different willingness to pay, and that the brushes and swabs that are most expensive are the ones that are most marketed. But there are many brands of brushes and swabs available that do work and that are not so expensive.
Okay, thank you. Joachim, I think it's an important question. I will reframe it a bit to make it a bit larger. But the point is that there are these initiatives which are, let's say, innovative, in both in high and low income countries. Is there any plan to monitor their impact? Because this can be enlightening for and inspirational for new countries. Maybe they are waiting, to see the effect and the results in Sweden or elsewhere, just to have leverage with their own political institutions and to make it happen.
I don't know what can be done on an international level. That's maybe better for you or Parta to comment on. I can only say that in my country, it's an ambitious plan to both evaluate it and immediately publish it as preprint because other countries need the data.
At IAC, we are part of a team that is looking at the impact of COVID in terms of, missing screening, missing preventive interventions, most importantly, delaying the diagnosis and treatment on mortality. So they are essentially collecting data, but then most of the, the outcomes will be based on modeling exercise. So they're trying to see what is the impact of COVID on cancer mortality. And then definitely there is already evidence that the cancer mortality is going to be higher because of the COVID-induced disruption.
Okay. Parto, there is a question very specific on the study from Patricia Villan that you have shown. And the idea is just to ask, what is the predominant type of cervical cancer screening that you have identified in low middle income countries?
So it was a mix of different types of screening tests. So for example, in most of the Asian countries, it was VIA. In Latin American countries, it was cytology. There was Thailand, which had recently introduced HPV testing. So it was a combination, but then majority of the countries, they had either VIA testing or cytology-based screening.
Joachim, do you have any data on the uptake of self-sampling in Sweden, and if this is affected by some socio-economical difference, for instance?
No, actually, the data that already exists and that we have been validating is for the women who didn't show up at a screening appointment, the non-attenders. There it is well seen that we achieve a higher attendance by sending these self-sampling swabs to the non-attending women and achieving a higher coverage, but also among the disadvantaged women. When it comes to this primary sending of self-sampling kits instead of screening stations, it's too novel. We don't have any data on that to say anything yet.
Okay. Parta, it's a very direct question. Maybe you can dig a bit in that. What are the cost implications of the last mile strategy?
Okay. Well, the cost implication for doing that kind of approach is it has to take into consideration several different aspects. First and foremost thing is that these last mile clinics, they are existent. They do have basic level of health providers. They call female health volunteers. So they have the providers there, they have the system there, but then of course they had to organize in a campaign mode, get all the equipment and other things. So definitely there is a cost associated with doing it that way, because it's not a regular clinic which was providing VIA based services. But then, if you think in terms of having a good coverage of the women, screening those women who have never been screened, and ensuring treatment of the screen positives using a screen and treat approach, this kind of last mile approach definitely would be cost effective. But then certainly I don't have any data or anything to prove that. But then this is something, an interesting approach. And then just think of this kind of approach being replaced, if we can replace VIA with self-collection of samples for HPV testing. Maybe that will be even a better solution. So these are the things these need to be looked at in more depth. But then at the present moment, I don't have any cost implication of this.
So again, for you, Partha, on the same line, do you, in low middle income countries, did regarding to the screening, the pandemic, did it increase the social inequalities in the sense people who were attending more well off and were still more advantaged, or is there, do you have any evidence for that?
No, we really do not have any evidence. Whatever evidence is there, it is coming mostly from the Western countries like USA. There is study that has shown that more disadvantaged population, they are being left out when there is this kind of crisis occurring.
I think, well, there are questions about, comparison of the sensitivity and specificity of HPV in self-sampling compared to smear test. I don't know if Joachim wants to go, but it's a long issue.
Well, I could say that there was older literature regarding self-sampling and healthcare or physician-taken test, where it was better to have a healthcare provider taken test, but those techniques at that time were not very sensitive. And ever since the advent of the PCR test for HPV, studies are quite consistent in that the sensitivity is the same. When it comes to specificity, it's when you do a systematic analysis of the self-sampling, it appears that there is occasional false positives that are obviously due to vaginal or vulvar infections that are caught during the self-sampling, but are not seen when you have a physician-provided taken sample. However, from a public health perspective, these differences are so small that they don't really matter, particularly not in a situation where hundreds of thousands of women don't get any screening at all. This very small difference in specificity was not really something that we dwelled upon.
Okay, thank you to both. We are 16 past 3, so I think we should stop with the Q&A.